I think we're all ready to start. It's 17 after the hour. I was wondering if you wanted to lead and do introductions, or I can go right into my portion of the slides.
Yeah, let's do introductions and make sure we know who we have on the line.
Okay.
So we'll start with Arkansas. I'm Amy Ollinghouse. I'm the Executive Director for the state chapter in Arkansas, and we have really enjoyed, I think I can speak on behalf of my colleagues in Louisiana, Oklahoma, and Texas. We've enjoyed this project and putting it together, and we look forward to implementing it with the practices that we've recruited. So Kristen, Ashley, and Dennis, if you guys want to introduce yourselves.
Sure. Hey, everybody. I'm Dennis Crow. I'm on the faculty at Arkansas Children's Hospital, a general pediatrician. I'm the QI lead for the chapter. Great to be here. Glad to see all of you here.
Hi, this is Kristen Pfeiffer, and I'm a quality improvement specialist and the project manager for the Arkansas chapter of the American Academy of Pediatrics.
Hey, I'm Ashley Davis. I'm a general pediatrician in Sherwood, Arkansas, and I've been out in private practice for about 11 years, and I actually graduated from LSU New Orleans, so I'm glad to be working with some Louisiana people.
Louisiana, do you guys want to go ahead and introduce yourselves?
This is Ashley from Louisiana. I'm the Executive Director.
Ashley, do you have any participants with you on today?
I don't have anybody sitting next to me, but Dr. Vicari with the Lake Pediatric Clinic is supposed to be on, so she may be one of these call-in numbered individuals.
Okay. Oklahoma, you guys want to introduce yourselves?
Hi, this is Amy Prentice. I'm the Executive Director of the Oklahoma chapter, and I believe today Dr. Darden may be on, and also it looks like we have some participants from the Oklahoma Latino Clinic that can introduce themselves.
This is Townsend Cooper, and I'm here with Kathleen Combs. We're two pediatricians at the Latino Clinic.
This is Paul Darden. I'm actually with the one that says Latino Clinic on it, and I guess I'm the QI lead for the Oklahoma chapter. And with me are
Marnie Dunlap, and I'm with OU Latino Clinic. And Natalie Connolly, and I'm with the OU Latino Clinic as well.
Awesome. Thanks for taking time to do this today. Texas, you guys want to introduce yourselves?
Hi, good afternoon. My name is Rachel Jew. I am the Public Health Education Manager for the Texas Pediatric Society. I don't know if Dr. Pilgrim King or her staff are on the call.
We are.
Hi, you want to introduce yourselves?
Hi, I'm Karen Pilgrim King, and I'm a pediatrician in Arlington.
Okay, is that all from Texas? Rachel, do you think?
Yes, that's it.
Awesome. Are there folks from the national office who want to introduce themselves?
Sure. Hi there, everybody. This is Jill Hernandez at the National AAP, and I'm the Manager of Immunization Capacity Building. And I'll be the primary contact between the chapters and national regarding the projects that are getting started here.
And I'm Kristen Girage. I'm the KETA Manager.
And that's it from the National Academy.
Thank you guys for joining us today. Again, happy that all of you guys were able to make time in your busy days. We appreciate you carving out the time from clinic and work to be with us. With that, I don't want to take up any more time. Let's just delve into this and get going. So, Dr. Kuo, do you want to go ahead and start?
Absolutely. So I'm going to take the next, I don't know, maybe 20 minutes or so and just go through some quick review of some QI basics and HPV while we're here. And then after that, we'll get into some of the specifics, the mechanics of the QI project. So glad to see all of you here. We've been doing a number of QI projects in the Arkansas chapter for the last few years, and so I know this is a real journey for all of us, and a lot of it is really a culture change that we want to be able to spread throughout the practices if we do practice transformation. So who's doing the slide advance? Okay.
Hi, I am.
Okay, cool. Okay, so a few reminders. We can make this, we want this to be, absolutely interactive. So since this is a relatively contained group, we can use the chat button, or feel free to just chime in if you have a specific question. Make sure that you put your phones on mute when not speaking to filter out background noise, but make sure you don't put your phones on hold, otherwise we'll start dancing to whatever starts playing on your hold function. Share your ideas and concerns. Definitely just talk. Anything that comes to your mind, we want this to be discussion. Next slide. And I don't have any relevant financial relationships or conflicts of interest to disclose. Next slide. From the 30,000-foot level, I think it's important for us to understand why quality improvement strategy is important for us in the practice of medicine. Quality improvement is a framework. It's a method framework for us to get from where we are today to where we want to be tomorrow. And it uses measurement to show us where we are on this journey, and it helps us understand when we've arrived at our destination. And I think the thing that we need to understand is how much of it really is driven by data, but the data does not need to be, a certain quality to be useful to us. So on the one hand, we don't want QI to be intimidating. On the other hand, we want folks to understand that QI really is driven by some objective measures, and we'll talk about that as we go through the project. And next slide. So the Department of Health and Human Services has really come out with the concept of better care, smarter spending, and healthier people. And the belief is that, by working, by really transforming the way we deliver health care through the tools that we have available to us, whether it be electronic registries or evidence-based care pathways, quality improvement, which all come together, that we can deliver better health care, that we can be smarter about our spending, and we can have healthier people. So everyone's interested in these three things: providers, families, and payers. But to achieve better health care, smarter health care spending, and healthier people, you really need to have an organized framework to get from here to there. And quality improvement really is that framework on how to transform the way that practice is delivered. It gives you the methods and it gives you the tools, but it also provides a learning community, because it's really not just about measurement and tools, it's also about bringing folks together. And that's why these webinars and this community exist. And the community we're putting together is on a district level for AAP. The AAP has been a real champion of quality improvement from the national level and individual chapter levels with the Chapter Quality Network. And so the district-wide is another community for us to be able to spread ways to improve care processes and outcomes. Next slide. So let's go to the issue at hand. So we've got a very well-defined issue, and we want to talk about where we are today and where we want to go. So human papillomavirus, as we all know, is a viral infection where 100% of sexually active men and women will be exposed to and acquire HPV at some point in their lives. So an estimated 79 million females ages 14 to 59 years are infected with HPV infection. There's 14 million new infections a year in the U.S. We all know about the links to malignancies, not just cervical malignancies, but malignancies in the oropharynx, penis cancer, various other types of malignancies, and HPV infection is most common in people in their teens and early 20s. Many of them clear, but many of them do not. And most people will never know they've been infected. And that's the reason that we want to have vaccination is because that's really the easiest way to prevent this from happening. Next slide, please. This is the ACIP guidelines and the AAP guidelines for HPV vaccination is that they are routinely recommended starting at the 11 to 12-year-old health supervision visit. As we all know, it's a 3-vaccine series. It is recommended all the way up to 21 for males and 26 for females. You can give it, however, starting at 9 years of age. Next slide, please. The trends in HPV immunization, however, is that they're not as high as they typically you would see when you introduce a new vaccine. So at this point, the HPV vaccine has been out for about a decade. And typically, you reach about 80 to 90% immunization after about 5 years. And that has been the experience for almost all of the other routine vaccines we give, including meningococcus when it was routinely recommended, varicella. But the HPV immunization rates have not risen nearly that high. You can see that there's a handful of states that sit in the 70% range, very, very few. More in the 60% range with many in the 50 to 59% range, and a handful that are in the 49%, less than half. And keep in mind that this is defined as estimated vaccination coverage with 1 dose, not 3, but 1 dose of HPV vaccine among females ages 13 to 17 years. So if you look at 3 doses of HPV vaccine, it's going to be much lower. That's down in the 20% range. If you look at males, that's also down in the 20% range. So we've got a long way to go. You'd expect typically that we would have much higher vaccine rates if we had followed typical trends for a new vaccine that's recommended routinely. Next slide, please. So it is useful to think about where the drivers are for high immunization rates. So in order for an immunization to be up in the 80 to 90% range, there's got to be, first there's got to be acceptance of the vaccine. If there is no consensus that a vaccine is necessary, then you're not going to get a high immunization rate. So another step is that there needs to be an awareness that the vaccine is necessary. So it could be within the provider community, or it could be within the patient community, but there needs to be awareness that the vaccine is available and it's there. The third slide, I apologize for that typo. The third bullet is there needs to be a reliable supply to the office setting, to the providers. It needs to not only be present in volume, but it needs to be affordable, so the healthcare payment mechanisms must be in place. A fourth area is that there needs to be a reliable workflow. So if you think about what it takes to get a child vaccinated, it has to go everything from the child and family need to be aware of the vaccine, they make an appointment, they come to the office, there's a supply there, the records are accurate, there's sufficient time to vaccinate, and it just goes all the way down. There's a lot of little steps that we all build into our immunization workflow, and it needs to be reliable, otherwise people will get missed. And when you use a quality improvement strategy, you have to sit down and think about where your blocks are. If you're trying to get from, say, 40% to 70%, you have to think about all the steps and assess where your opportunities are. And we'll talk about that. We will offer you, and in the course of this discussion, we'll go by what the CDC is really recommending or advocating, but you want to make sure that it is also something that is specific to what you feel like you need to be working on to increase your own HPV rates. Next slide, please. So one of the fundamentals, packages for quality improvement is something called the model for improvement. Okay. So there's three fundamental questions. This is very, very simple. Let's go ahead and show the whole slide. There's three fundamental questions. The first is, if you have an issue, then you have to ask yourself, what are we trying to accomplish? So that's when you define your aim about what you're trying to accomplish and where you want it to go. The second question you want to ask yourself under the model for improvement is, how will we know that a change is an improvement? So once you have your problem, you have to determine how you're going to determine that you've actually made an improvement. So you can't just say it just looks a little better. You need to have some sort of an objective determinant that says that you actually made improvement. The third part of the model for improvement is, what changes can we make that will result in improvement? And next slide, please. So this is another way of looking at the model for improvement. So you start with, what are we trying to accomplish? You always ask yourself, what are we trying to accomplish? The second thing is, how will we know that a change is an improvement? The third thing is, what change can we make that will result in improvement? And this is when we get into something called PDSA cycles, or Plan, Do, Study, Act. And we use Plan, Do, Study, Act cycles repeatedly to help us make incremental changes to be able to get from where we are to where we want to go. And a big part of PDSA cycles is actually doing them correctly. We see a lot of folks where it takes a few cycles before they really understand the power of the PDSA cycles. And we'll go over that as we go through the project. Next slide. As you are figuring out how you want to proceed in any sort of QI project, it helps to write something called a SMART aim statement. So a SMART aim statement, SMART is an acronym that stands for the specific bullet points below. Your aim has to be specific, it has to be measurable, it has to be action-oriented, it has to be realistic and relevant, and it has to be timely. And the reason that's important to write an aim statement that is SMART is because it really gets you and your team down to a very quantifiable, very specific, very time-oriented, manageable objective so that you know where you want to go as well as where you are today. So if you say, I want to make my immunization rates better, that's not measurable and it's not specific. If you want to say, by May of 2016, I'm going to increase my HPV immunization rate for children coming in at the 11 to 12-year visit from 55% to 75%, that is a specific, measurable, action-oriented, realistic, and timely SMART aim. And we will want you to think about SMART aims as you go forward, because writing a good SMART aim actually takes a little bit of thought, but it's well worth the time necessary to make a good SMART aim. Next slide, please. Now, for PDSA cycles, what you do is to decide what little change you want to make to try to get you a little bit of the way to your SMART aim. Okay. So PDSA cycles are not just one thing. There's a series of steps that you take to get you to your, let's say you want to make sure your 11-year-olds are receive the HPV vaccine at their checkup. A PDSA cycle understands that you're not going to get to your 75%, in the first month. But it does mean, however, that you make little steps along the way and you collect some data along the way and you look to see if you've made a little bit of a step, and then you decide what you want to do after that. And then you keep doing this over and over again. So plan means that you figure out the questions you want to answer, you plan a way to answer the question, but you also have to predict what's going to happen when you do your change. The do means that you just do it. The study means that you examine your results and you talk about what you learned, and your act is that you decide what you want to do for your next step. And it should be in response to whatever you learned by studying your do cycle. What you do next after that means that you could adapt what you did you could adopt what you did, or you could abandon that course and then you take the next step. So that the key is that you want to predict what's going to happen when you do the PDSI cycle. And you study results and you adapt to your next step based on what you learned from your previous PDSI cycle. If you discovered something that really made a difference, like you found that all of a sudden you're going to 60% acceptance rate, then you want to move forward. If you find it didn't do anything, then you retool and you do something else. Next slide, please. And this is just a schematic that shows that your PDSA cycles, as you do them repeatedly, will get you to where you want to go, but you have to do them repeatedly so that you build momentum over time. And you can see that you're going to start with very small tests because you want them to be achievable and not overwhelm you. Then over time, as you repeatedly demonstrate that your changes are making a difference, then you can go to wide-scale tests of change, and then you've got your entire clinic doing it. So an example of a small test is that you try an intervention on, let's say, 5 patients for 1 physician. And an example of a wide-scale test of change is that everybody in your office is spreading the entire change package across all the patients that they see. But you want to start small, and you want to learn what you from your results, and then you gradually spread your changes over time. Next slide. We're going to be talking about PDSA worksheets, and we find that these are very good tools to help you learn how to do PDSA cycles, because it helps you commit your plan and your do and your study and active paper. It also helps us learn and understand what's going on within the individual clinic setting. And don't worry about the quality of exactly what you put down there. It's really the act of using a tool to train yourself how to do PDSA cycles is a really valuable thing. And we've done this in Arkansas with many of our chapter members, and they found it really useful. Next slide. Okay. Let's go back to HPV for a little bit. We know that the rate of HPV vaccine has not been terribly high, and the research that's come out of the literature suggests that we're just not recommending it as strongly as we need to. And if you think about how we recommend the 2-month-old vaccines, or what happens when an 11-year-old comes in and we know they need the tetanus shot. You know, and we walk in and say, today we're going to do this vaccine, we're going to do the pediatric vaccine, rotavirus, pneumococcus, HIV, or today we're going to do the tetanus shot, we're going to do the meningococcus vaccine, and oh, there's another shot called HPV. And what the research is suggesting is we're not recommending the HPV quite as strongly as the other vaccines that we give. And I'm sharing with you here some really hot off the press manuscript results. This just came out in the February issue of Pediatrics, where a national survey examined both pediatricians and family medicine physicians. I'm showing you the pediatrician results here. 67% of pediatricians in this national survey always discuss HPV at the 11 to 12-year-old visit. And 60% of pediatricians strongly recommend HPV for females at the 11 to 12-year visit. That figure goes down to 52% for males. And think about what would happen to our Tdap vaccination rates if we treated, if we only discussed the tetanus booster or the tetanus pertussis booster in this manner. You know, only 2/3 of us recommended it. Only 3/5 of us actually strongly recommended it. And so it may be not a surprise that greater than 25% of our parents actually end up deferring the vaccine if it is actually discussed. And then the reasons for pediatricians not wanting to talk about the vaccine is associated with the expectation that the parents are just going to say, no, my child's too young, my child's not sexually active. However, if there is a really strong recommendation, just like the way we recommend other vaccines, the rate of vaccination for HPV does go up. And there are practices nationwide that have their HPV vaccine rates in the 80% range. Okay. Next slide, please. This is a slide that comes really from the CDC. The data shows that the strong recommendation really is the main reason that parents decide to vaccinate. And this is true no matter what the vaccine is. A strong recommendation is valued by almost all parents and makes a big difference in the vaccination rates. Other issues include not sexually active, whether there's a safety concern, it's not needed, or there's a lack of knowledge. Of course, you know, the fact that there are a percentage of pediatricians that do not recommend HPV is a concern as well. But the CDC's data on HPV vaccine is that many mothers who were studied in focus groups stated that they trust their child's doctor and would get the vaccine for the child as long as they received a recommendation from the doctor. Next slide, please. So for HPV vaccine, we recommend that the HPV vaccine is recommended the same way and on the same day that you recommended Tdap and the meningococcus vaccines. A strong recommendation from you is the main reason parents decide to vaccinate. You can say your preteen needs 3 vaccines that provide protection against meningitis, HPV cancers, and pertussis. And also, hearing that HPV vaccine is cancer prevention. Cancer is really the word that gets folks' attention. They help understand, parents understand, and make the decision to vaccinate. You know, and it is a cancer vaccine. If you came out and said, I'm going to prevent 20,000 cases of cancer a year, I mean, which is the truth with HPV. That's a different understanding and discussion compared to if they say, well, it's designed to prevent genital warts. And so we need to make sure that parents understand why the vaccine is needed at age 11 or 12. Let them know that, like any other vaccine, they want their children protected long before they're actually exposed. And your personal belief in the importance of HPV vaccines is important. You want folks to understand that you've given it all to the children in your own life. Next slide. Now, of course, at any time you do an HPV vaccine QI project or any QI project, this is not I'm going to do it all by myself. And so when you do quality improvement of any kind, forming a team is a critical component of quality improvement. So, for example, you know, we have focused on a provider message, but other things that may come into play is that you have to determine what are other components of your vaccination workflow that may contribute to increasing your immunization rates of HPV for 11 to 12-year-olds. So, for example, it could be you're not getting enough for your 11 to 12-year-olds in, you want to do reminder recalls, and that's going to take other folks in your office. You're going to need to assign somebody to make sure that they do chart audits and understand where you are today. You may choose to increase awareness by putting materials in your waiting room or in your rooms while the teenagers are waiting or the families are waiting. And so that speaks to the idea that to affect change, you need to do a quality improvement team. And this is something we talk about a lot in the QI circles, is that forming a team is critical to the success of change. You want to determine your roles within a quality improvement team, and your team wants to foster an environment of quality improvement. What I mean by an environment of quality improvement is that folks are on board and understand that you're about using data and a culture change to get from where you are today to where you are tomorrow, to where you want to go tomorrow. You want to understand the nature of your problem and the steps needed to address the problem. And you need to understand where your baseline is. Because what we've done here is given you national numbers and in some cases state numbers, but every practice and every environment is different, and you need to look at your own workflow, look at your own operations, and see where you are today. Because the interventions that we recommend for a practice that is vaccinating in the 30% range versus the 70% range is that the drivers may be different for change. And so we will talk as time goes on much more about fostering that quality improvement environment, understanding your workflow and understanding your baseline and determining your baseline. In fact, what everyone needs to be able to do going forward is understand where you are today. And we can talk about where we are today before we go, as we go into this project. I think the next slide is the last slide, and I'm interested in hearing input from practices on the call about where they think they are today and where they want to go. But this last slide is that data is really critical to success. We've talked about how data is really, really super critical, but I also do not want folks to be intimidated by the word data, okay? A data could mean anything from like a big administrative database with lots of fancy doodads, but one single patient with one single experience is also a data point, and you can learn from that. Now, of course, one person is limited to that one person, but you can learn a lot from one person. And so you can collect your own data, and I want folks to be comfortable knowing that you don't need to do anything fancy. You'll always learn on one patient. You'll learn on 5 patients. What you need to do is understand where you got your data, what you can get out of it, and what its limitations are. And the reason we want you to be comfortable just doing even basic things like chart audits is that data really needs to be timely in order to help you with quality improvement. And one of the things we hear is that if you do a quality improvement project, why don't we get the data from X source or Y source? Like, could we get the data from our payers? Could we get the data from our registry? And you can, except a lot of times those data tend to lag behind what you need in order to conduct PDSA cycles. So you want to be able to do your own data collection. And it can be as really simple as a couple of chart audits, or you can run your own inquiries through your EHRs, but you need to be able to do your own. If they're delayed, they become a report and not quality improvement. So we'll want to discuss that more and more as we go on. So I'm going to take a break from talking because the next slide after that is data entry and MOC Part 4. So I would like to open up the call. I am interested in hearing the reasons for why you want to be in this project and what you think your HPV vaccine baseline may be. And I'd love to hear some thoughts on that because that will also help us as we design and move the project forward and understand where we need to go. So comments? And don't forget that you're likely on mute.
This is Karen King. I'm in Arlington, Texas. The reason I wanted to join this project is part of why I do PEDS is it's a population I think where prevention is really important, and I think that this vaccine in particular can make a huge difference in young adults' lives, actually. And I'm not really sure what my practice rates are, if I just think anecdotally, my own experience, I'd probably say maybe about 55–60% of the parents will agree to vaccinate, and I strongly recommend it. And just in listening to the talk, one of the things that I'm interested in doing is to see what, in my particular population, what the barriers are to the vaccine, to this particular vaccine. So I'm thinking maybe I'll do a questionnaire, and at the end of their visit, ask them, you know, did their provider talk about it? Because it's myself and an NP. And whether they were given a chance to ask questions, and if they plan to, why not?
Okay.
But I think just off the cuff, I would guess 55–60%.
Okay. And do you have a sense as to, so here's an example of a very elementary PDSA cycle. The very good idea to do, since when you say you think it's probably 55%, here an example of a PDSA cycle is that you collect data and see what your rate is for a week of, say, 11 to 12-year-olds. And your prediction is that you think you're going to find that as 55%. Because you feel that you make a strong recommendation, but there's some other factors. And then at the end of the week, you say, well, was it somewhere around 50 to 55%? So I think that those are I think those are excellent comments. I think they've hit the nail on the head. You've got a sense, I mean, I should say, we've all got a sense of what's going on in our practices. It's about, you know, making a prediction of what we think we're going to find. And I definitely encourage folks, as Karen, you said, you want to get a good understanding of where you are, before you start trying to make any wholesale changes. And I think one example, and another PDSA cycle may be, let's do a questionnaire, and this is what I predict we're going to find at the end, and then you go from there. So thank you for your comments. That's awesome. Other comments, other thoughts?
Hey, this is Paul Dennis.
Hey, Paul.
We're Latino Clinic, so we're doing it because Eve Schweitzer told us we had to.
So Eve Schweitzer spent a strong recommendation.
She did. She made it. She was very convincing. And actually, because Marnie, who actually had to agree, was willing to do it. We actually looked at our HPV rate in Latino, and for all 3 doses, 13 to 17 years of age, about a year ago, it was 75%.
Wow.
So, but we want to be 90.
Okay. So one thought I have for us, so this comes back to the learning community part, is that there's going to be variation between practices, and we want to be able to give the folks, we want to be able to have a community for folks to share what seems to work and what challenges that we face as we go on. So I think we'll all want folks to see where their baseline is. 75% for all 3 doses is high. Is definitely one of the higher rates that I have seen. 75% for 1 dose is pretty high. 75% for 3 doses is very high. I'd love to see y'all get to 90. But since 75% for 3 doses is a high performing statistic, that's a good opportunity to discuss that. We'll definitely want to hear your experiences with strategies of what may be driving 75% for all 3 doses. So thanks for sharing that.
I am only the data collector. Marnie and the others are the ones who are doing the work.
Is it Marnie and who else is on with you?
Townsend and Kathleen.
Oh, I turned up. No, say it again.
Yes.
Natalie, Townsend and Kathleen.
Yeah, any thoughts you have to share? Since they said this is a community of folks who are doing quality improvement. So I was wondering if you had any thoughts about, you know, the 75% figure and, you know, how it aligns with the strong recommendation, or what other, you know, or what other things. A strong recommendation in my mind is one component of vaccinating, but it's not the only. It's far from the only. Try to get your rates up.
Yeah, I mean, I think a couple things work in our favor. One, we have a little more homogeneous population of mostly all Hispanic populations that generally tend to take vaccines a little better. Then we also have a strong presence of our MA's recommendations, and then our providers also.
Okay. Do you have a, what's your sense about today, again, this is a prediction, on what you would want to do to get it higher than 75%?
You know, we've been working on kind of different prompts, which have had varying success. I would love to get a new EMR, but I don't think that's going to happen. So figuring out some kind of recall reminder may be the next thing we try to tackle, but I don't have a great feel of exactly how we'll accomplish that.
Okay, that's part of the part of the QI project.
Right.
Okay.
Can I chime in for a sec?
Absolutely.
We have a fairly, of the people who do accept our vaccines, oh, this is Karen King again from Arlington.
Hi,
the
Karen.
people who do accept our vaccines, we have a high completion rate because we make all their appointments, when they get the first one, we make the second and third appointments at that point, at that time, and then we give them the reminder calls to get them back in. So we don't wait for them to call us back. So I don't know if that helps, but
that's very, yeah, that's very helpful. So a couple of comments there. The first is that the 11 to 12-year-old visit is critical. According to the papers that are out on this subject, if parents accept and vaccinate their preteen at 11 to 12 years, there's a much higher likelihood that they'll complete it for any number of reasons, including the ones that you've mentioned. I think those are excellent comments. The other is that if they defer the vaccine at that age, there's a fairly high likelihood that they won't start the series. So I think you've raised some really good points there.
Hey, this is Ashley Davis from Sherwood.
Hey, Ashley.
Hey, we at our clinic probably have, I would predict about a 55 to 65% HPV #1 rate. And one of the reasons I joined this is because I feel like I've hit a roadblock. When I encounter a family that is not interested, I haven't really been able to get around them. I haven't been able to encourage them, even with a strong recommendation, to take the series. I think I can think of two off the top of my head that actually did it in the last year, and it's just that there's such a fear factor with some of the side effects.
What are some of the things that you've heard?
Well, there is apparently someone in the local area that had Guillain-Barré associated with the vaccine who's very, very vocal on Facebook. And that particular community, it would be interesting to study that community to see what their rate is, because the people that are from that town really have a hard time accepting a vaccine because of the fear. And so just trying to kind of push through that and come up with a good way to further encourage them, #1, and then #2, once we get that first vaccine, to go forward with the series of 3.
Have other folks on the call encountered? I mean, I've definitely heard the Guillain-Barré thing. Which there isn't a link, but as we know, have other folks encountered that? And again, this is being a learning community. I'm interested if other folks have addressed that issue or encountered that concern as well on a community basis. And actually, thanks for those comments. Those are great comments.
Oh, hi, it's Karen again.
Yes.
I have encountered that, and the question about Guillain-Barré and whether there were also blood clots, I think, was the other concern that had been circulating on social media. And I usually tell parents that, you know, we are very careful about anything that we use, including vaccines, and we do what's called post-marketing surveillance. And I say that so that anything that happens in that time frame after you get the vaccine is reported and considered, but it's been studied and it's shown that while it may have happened in that week after, it has not been linked to it. So I address the issue that they, whatever they've seen on Facebook, and I let them know that we have considered and studied it and there hasn't been a link. And usually that seems to work. There's still a few who say, well, let me think about it, but that's how I try to get around that issue.
Great, thanks. Ashley, I think I think what you've mentioned is that you've studied your issue, and this is terrific stuff. You've studied what your baseline probably is, and so I don't think it'll take long for you to verify that. Obviously, if you find that your baseline's 30% or 70%, that you may alter your strategy a little. But what you've also done is think about what are the drivers for that. And the QI framework goes through what are little things that you can do here and there that you can then pick up steam to try to address that issue. I think Karen's given an example of one possible intervention that we could go through. But I think those are those are excellent comments.
This is Jill Hernandez at the Academy. I just wanted to throw in a tidbit, and I'm not a physician, so this is just what I've heard from others. But in situations where they've encountered some of these more community-based hesitancies, whether it's, we've seen this in a couple communities in Wisconsin and across the nation, that sometimes they've seen that, by offering back the, oh, well, it's been studied and it's okay, doesn't always put people's mind at ease. But that's where the opportunity to say, well, I believe in this vaccine, and because I believe in it, I have vaccinated my son, daughter, granddaughter, niece, nephew, best friend's child, whatever that may be, and bringing in that personal attestation to the vaccine is sometimes more of a strong response than trying to come back with data. Just a point.
Yeah, thank you. Awesome. Okay.
So
go ahead.
So one of the things that I find the most interesting to deal with, or the least interesting actually, is the non-specific concern. I just don't want to. And and I've actually quit trying to drill down because nobody ever seems to be willing or able to tell me. I mean, mostly then I just make a couple of positive statements. One about it's very safe, and man, this prevents cancer, and it works sometimes. So, but the non-specific I've always put me off as to it's sort of like fighting shadows. What do you say?
Yeah. Is that a question, or is that for the group, or is that just sort of just an observation before I ask folks to kind of
all of the above. If anybody has a better way of dealing with it, I'd love to hear it. It hasn't seemed to be incredibly effective. It is sometimes effective, but
what do folks think? The non-specific, I'm wary of vaccines, or I'm wary of a new vaccine.
Dennis, my overall sense is that because it is not a required vaccine, it is just a recommended vaccine, that has an impact on people. They feel like, well, why is this one just recommended?
Yes.
Why is it optional? Because really what they were saying in the Latino clinic, I get that a lot with the flu vaccine. I mean, so many times.
Yeah.
It's real specific. And I think, again, it's because it is a recommended vaccine, and that puts it in a different category.
Yeah.
Even if they don't emphasize it as much, they know that they don't have to have it to go back to school.
Right.
So it's in a different category for them.
I do think it's part of the story. An analogy would be the meningococcal vaccine, because the uptake, though, of the meningococcus vaccine is typically higher. It went up faster than when it became recommended in schools. So there are, to my knowledge, 2 jurisdictions that require HPV vaccination for school. One of them is Virginia, and the other is Washington, D.C. So in our entire district, there are no statewide school district recommendations to have HPV vaccination, although it does exist in Virginia and D.C. But I think that knowing that some of these vaccines are, like the meningococcal vaccine is a very high uptake, and that also took about a 4 to 5 year period. And meningococcus was only required for school for Arkansas in the last year. So I think that it's part of the story, but I do think that I definitely think that there's room for us to be able to go up. And I do think that that is why when we write SMART aim statement, that we think about what we can do that's realistic. I don't think that we can all get a consistent 70 to 75% all 3 doses in the next 6 months, because that takes time, and that's some fantastic work that takes place over time. But I do think that what we want to do is set goals that we think are achievable in a short period of time, and use that knowledge to just keep going after this project is done.
Dr. Kuo, this is Amy.
Yeah.
I have 2 things. First of all, I think you mentioned that these PDSA cycles need to be run weekly, but this is a monthly. I just want to clarify. We're only inputting data on a monthly basis. So shouldn't the PDSA cycle be a monthly PDSA cycle, so you're not running 3 interventions in a month?
Right. So when we talk about data, the data that we're really collecting is the data on the vaccines, on the vaccination rates with the chart audits. What I mean by data is for PDSA cycles is whatever it takes for you to be able to understand whether the PDSA cycle has had their achievement or not. So let's say, for example, that you're going to do a chart audit as your first PDSA cycle. So that's not going to be data that you're going to enter into AKITA. That's just by the end of this week, I'm going to predict that out of 10 charts I audit, that 5 of them are going to have an HPV vaccine. That 5 of them are going will show that the preteen was vaccinated, and at that visit. And so your data is that you completed the PDSA cycle and that your baseline was 50% for that group. And then you decide what you want to do the next week. And I understand that weekly PDSA cycles are, can be difficult, particularly during flu season. But the reason why we recommend trying to do small but frequent PDSA cycles is that it builds momentum for the team, for the QI team. And we want to run that balance between having us get together at a reasonable frequency, but not too often and not often enough. But I find that if you do PDSA cycles monthly, you kind of get bogged down because you lose momentum.
Okay, thank you for clarifying that.
They could be really small PDSA cycles, but there should be some sort of at least a touch base. And another example is that if you couldn't get the PDSA cycle done, then you learn why you couldn't get the PDSA cycle done, and it may be like a lack of time or somebody was absent from the office.
Okay.
And that's okay. And that's
Thank
good.
You, Dr.
It's
Kuo.
valuable learning. Okay, so we've got we got less than 20 minutes left, so I want to make sure that we get time for the rest of them. This has been a great discussion, and I think that I really look forward to hearing more and more from folks as we go forward. So can I hand it over?
Sure, I think that was my cue. This is Jill Hernandez at the Academy. Is that all right, Amy, if I move forward?
Yes, I would love that. Thank you.
All right. So this is Jill Hernandez at the Academy, and I'm just going to give you guys a quick overview of data entry for the MOC Part 4 project. Amy, if you could move to the next slide for me. So for MOC data collection and reporting, your practices will be using the AAP Quality Improvement Data Aggregator, otherwise known as QIDA, and data collection will be for 3 consecutive data cycles collected over 3 months. And to the point that Dr. Kuo and Amy were just getting at, we're collecting data monthly for 3 data cycles, so for 3 months. So charts will be entered into QIDA, but that doesn't mean that you can do smaller tests of change throughout that month. So maybe taking a look at, the next 5 patients that I see, how do I give the recommendation and do they accept the vaccine? Definitely smaller tests of change can be done throughout the month. We're just going to be entering data into QIDA for over 3 data cycles over 3 months to kind of see what those bigger changes are based on what those small tests of change are done in the practice. The sampling strategy at the practice level will be 10 charts of consecutive eligible patients seen that month, and that's at the practice level. So not if you have more than 1 physician participating in a practice, it'll be 10 charts of patients seen by the participating physicians, not each individual physician's patients. So that way we'll have, you'll have a larger number of charts to pull from. Again, the number of data cycles required will be 3 consecutive data cycles, and that's a requirement for being eligible for MOC Part 4 credit. Practices are welcome and encouraged to collect data for more than 3 data cycles if they would like. The QIDA data entry tool and monthly practice project update will be the data collection tools, and I'll get into a little bit more information about those. And again, the length of participation for MOC eligibility is the 3 data cycles over 3 consecutive months. You can go ahead and switch slides. So for MOC, the required measures that the projects will be focusing on are geared around series initiation for the HPV vaccine. So when we're looking at series initiation, we're looking at a chart pull criteria of 10 consecutive charts of patients seen in the practice during the month, age 11 to 12, who are eligible for dose 1 of the HPV vaccine, with the exclusion being patients with a valid medical contraindication. And then this just explains the measure definition. So we're trying to look at the percent of patients who have documentation that HPV dose 1 was given by age 13, with our target population being eligible patients for dose 1 of HPV vaccine age 11 to 12 in the practice. So we'll be comparing the number of patients age 11 to 12 in records examined who received HPV vaccine dose 1 compared to the number of patients age 11 to 12 in the records examined, so the 10 charts that are looked at. You can go ahead and flip slides. Oh, go ahead.
Is this 10 per practitioner or 10 per practice?
10 per practice. You can enter more than 10 charts if you would like, but the minimum is 10 per practice. We do have some smaller practices that we're working with that might have trouble getting to 10 eligible patients just based on their the number of adolescents that they see. So, we can accommodate that as well, but for our goal is 10 charts of eligible patients from the practice. And then this is just a quick screenshot of what the actual QIDA data collection tool looks like. So when the practice goes in to enter their data, this is what they will see. And down there at the bottom, you'll see question 1, please identify the age of the patient. It's a click on either age 11 or 12 because that's the criteria for the chart pull. And then the second question is their documentation that the patient received dose 1 of the HPV vaccine series. And that's another yes/no question. And that is the data entry. It's pretty simple. So that way we can assess what number of patients in the chart pools actually received the vaccine. And for additional guidance on how to use QIDA, your chapter leaders have they'll be sending out, if they haven't already, I think they might already have sent out a YouTube video that has a QIDA data entry example, so kind of go step by step into how to do that. So that should be helpful.
We have sent that out, Jill. Thank you.
Yeah, no problem. And if there's questions along the way, we can help. And I think we can go to the next slide. So for the MOC completion criteria, just really quickly, consecutively submit practice level baseline data and an additional 2 consecutive months of data for 10 patients per practice using KETA, and also annotating run charts in KETA, and there's examples of explanation of how to do that in those demonstration videos. Implement the project intervention, which for this aspect is the strong provider recommendation, so giving the strong bundled recommendation for the HPV vaccine. Participating in 3 team meetings, calls, or webinar where data is reviewed and ideas for change are discussed, so calls similar to this where you're talking with your peers about what has been going on in the practice and what ideas you guys have for moving your project forward. Reviewing run chart data in KETA on a monthly basis and implementing PDSA cycles based on the learnings from that data, so just what Dr. Kuo has been talking about. And then submitting the monthly practice project update forms, which will be in SurveyMonkey. Then these are just questions to help us keep track to make sure that the practices are keeping up with their end of the project for MOC completion. You can go ahead and switch. And this I just put in here as a quick visual idea of the project oversight and leadership structure for the project. So what we're really looking at today from your chapters will be the ones to provide reports to myself here at National and monitor the practice participation. The practice leader, which should be identified from each practice if there's more than one physician participating, they'll be the ones to provide the reports to the chapters to make sure that data is entered into KETA, complete the practice project update forms, and monitor the local physician participation, keeping track to make sure people are participating so they're on track to receive MOC Part 4 credit. And then the practice participants, the other physicians that are involved in the project at the practice, will work to review the data from the charts that are entered into KETA, implement the changes, so implement the key strategy of giving a strong bundled recommendation for the HPV vaccine, and otherwise actively participate in the project. You can go ahead and switch. So the practice leader, I put this in just as a little plug. Each participating practice, as I mentioned, should identify a practice leader. And again, that practice leader helps to maintain the basic information about participating individuals from the practice. They ensure that the data is entered into KETA for 3 cycles over 3 consecutive months. They're the ones who are in charge of making sure the practice update forms at the end of each data cycle are submitted, and they understand the responsibilities of attestation and dispute resolution, which we have information for everybody on that as well. You can go ahead and switch. All right, I think we're ready for any questions, both for anybody on the call, or if you want to have further discussion about potential interventions, that's fine too.
So when would the data collection start?
Amy, what is your plan for getting the practices started?
Yeah, okay, so the data collection will start in the month of March. What we have proposed, and so that will be your baseline data collection month, will be March. We're proposing that the data be due the 4th Friday of each month. Okay. And then we will have a webinar to go over the data and talk about, you know, tweaking interventions and PDSA cycles the following Thursday after the data collection is due.
Okay. So it'll sort of turn over, well, I guess when it's due, then it will sort of start the next month.
Yes.
Does that mean that you'll have a different date each month for when the cycles stop? Because I think on the videos it talked about the cycles automatically turning over on the 30th of every month.
You know what?
Like the data entry cycles.
Can somebody from National clarify that? I'm not sure.
I think that's
sure. Yeah, so if that's what works best for the practices and the chapters implementing the project, we can make it so the practices can close their own data cycle rather than it closing on the 30th. Most other chapters are having automatic close, but we can definitely be flexible in making it work best for what your schedule is.
Probably an automatic close would be fine. I mean,
so maybe not on the 30th, maybe a different.
Yeah, because if we're going to do the last Friday of every month, that wouldn't necessarily be the 30th, and so I didn't know then if the data reports would be totally accurate if your next month was included, you know, the first week after the 27th or whatever it ends up being. So.
Okay, that's a great question. Sure. Let me think through.
Amy, Kristen and I can work with you on that and make sure it works out. Okay.
All right. And then I'll send out a clarification for when the data is due and when we'll have the webinar. We felt like this Thursday time slot was good for most people. You guys, with enough time warning, were able to make it. So we were hoping to do the webinars maybe the first Thursday of the following month. Or the first Thursday of, the month. So, let me think through that. So, are there any other questions?
We had something.
I think they answered, I guess, with baseline data.
Oh, right, they did. Yeah.
Do you guys think that this is doable? Do you feel good about it?
Yeah, I think it's doable.
I think it's doable.
Okay.
So are you saying that we don't start collecting data till March 1st?
We don't start collecting data till March 1st. That is correct.
Through the 20th and then 25th, everything will be due, and we'll meet on the 31st. That's kind of how we're looking at it right now.
Well, yeah, I want to make sure that those data cycles have the same number of days in each cycle. So I'll confirm with National and I'll get back to you on that. But just, your first data collection month will be March. We'll figure out if we want it to close automatically or to have a hard stop on a certain date. Your next data collection, which will be, your first data collection with the intervention will be April, and then you'll have another data collection with another intervention in May.
Great.
And we'll wrap it all up in June. Do you guys have questions about KETA, how to enter the data, how to get logged in, any of that kind of stuff?
Amy, I don't think I've received any kind of information about that. Is there a certain email that was sent out?
Was somebody else going to say something?
This is Jill at the Academy. We'll double check the lists that we have received as far as rosters from all of the chapters and make sure that we have everybody listed on there. If we've missed someone, we'll get those folks invited to the KETA site as soon as possible. But you should receive an email from, is it a general KETA?
Yeah, it's our KETA administrator account, so the email will come from qidata@aap.org. So once we have everyone registered and set up in your practice groups, we'll send out those emails. So just kind of be on the lookout for that to come through your inbox in the next week or so.
So let me ask you guys this. Do you guys want to get together one more time and have some sort of discussion before the data collection starts in March, or do you think that you feel pretty comfortable in being able to start the project without another touch base, knowing that, your chapter leads are here and available to assist.
I don't feel like we need another meeting. I feel like I understand it pretty well.
Awesome. Okay. Well, let's do this. If individual practices have questions or kind of get on a hump that they can't, that they're struggling with, if they just reach out to their chapter contacts, and we'll work as a district to get those questions answered. And maybe we'll also set up a listserv for the participants within the district, and as those questions are answered, maybe we'll generate, the question and the answer to the larger population, just in case somebody else is dealing with the same issue or has a similar issue. And then that way we can work to disseminate information between and kind of share information between our small group. Does that sound good?
Yep.
Okay.
Sounds good.
All right, guys. Well, we have 2 minutes left. I'm happy to give you those 2 minutes back in your day if nobody else has any further questions or comments. Are we good? Okay, I'm going to take that as a yes. You guys, thank you so much for your time and participation today, and we look forward to working with you, and we'll be in touch with more specifics in the coming days and weeks. So thank you all, and have a great day.